Our next lecture is an overview of medical genetics, why, what and how. I request Dr. Payal Kamdar to continue with the lecture. A brief introduction for Dr. Kamdar. She is a consultant clinical genetist at Setgene Laboratory, Ahmedabad, and also at KD Hospital, Ahmedabad. She has also served as consultant clinical geneticist at Institute of Genetics, Ahmedabad, India. She was a consultant and head of the Department of Pathology Laboratory, Shri Kachhi Jain Hospital, Ahmedabad. She has done her postdoctoral fellowship in clinical genetics at Christian Medical College, Vellore. Welcome, Dr. Payal Kamdar.
Good afternoon, everybody. Thank you very much for such a warm welcome, and I hope that this is post-lunch session I had tried to make bit interesting for all of you. So without wasting any time, let's start with today's topic, medical genetics. So what it is basically. Excuse me.
Should be.
So what is medical genetics? It is the branch of medicine that involves the diagnosis and management of the hereditary disorders. Let's look up the three components of the medical genetics. First will be the phenotype and patterns which give us clinical diagnosis. Next will be the genotype which gives us the molecular diagnosis and will help us in the genetic counseling. And because of these two components, now medical genetics has reached to the stage of gene therapies. Now let's look up the genotype as a molecular level. If we see that inside the cell will be the nucleus, inside the nucleus there will be a chromosomes. This chromosomes we had packed the nucleosome. Then what is nucleosome? Nothing but the DNA which is wrapped around the histone proteins. And what is gene? Nothing but a stretch of nucleotide ATGC. So if we go through this line, we have a spectrum of disorders, might be a chromosomal, single gene disorder, imprinting disorders, or it could be multifactorial. Now let's see how we can apply this genetics in clinics. So whenever we had any such patients, we had to first go through from the history to clinical examination to all the pedigree charts, and we have to define the phenotype of the patients. Once we have the phenotype, then next step will be what are the supportive investigations which might be needed. Then if it is fitting into the kind of genetic disorders, next thing would be whether it be a chromosomal or it be a single gene disorders. Based on that, we have to decide which genetic test will be indicated. It might be a karyotype or a single gene or a panel of gene or clinical exome, or there can be multiple tests we have to select on. That will give us the molecular diagnosis, and this will ultimately help us in the genetic counseling and management of the patient. Now to make it bit interesting, I had taken here some case scenarios which we see in our clinics. Let's look up the first case. She is a 33-year-old lady, history of previous 2 pregnancies which were terminated because of swelling in the back of the head, and head was not properly formed. So suspected to be neural tube defect, probably encephalocele. So the first thing which usually we think of, deficiency of folic acid, right? But here she already took periconceptional folic acid. They had sent this case for genetic consult, And in detailed investigations, what we found is, apart from occipital encephalocele, there is also a polycystic kidney, and one more thing is one extra finger, that is post-axial polydactyly. Together that defines the phenotype of Meckel-Gruber syndrome, and we had confirmed this by genomic testing, which is an autosomal recessive condition, and there is 25% recurrence risk. So clinical correlation of the genetic test is very much important. Message which I would like to convey here is, whenever we had such sonographic anomalies, dysmorphologic evaluation with radiological studies, and if required a histopathological examination should be done, and it should be followed by genetic testing if required. Let's look up the next case. A 2-day-old neonate, second born to non-consanguineous parents. They sent the genetic consult for unilateral cleft lip. There is no antenatal, natal or postnatal complications. Now when we had draw the pedigree here, if we can see here a proband similar features we had seen also in the sibling and in the mother. Let's look up the photograph of the child. If you can see here, along with the cleft lip, there is some pits in the lower lip. Now let's look at the photograph of the mother. Mother also have some pits in the lower lip. So as we know that cleft lip or palate are usually multifactorial, but will it be a genetic possibility? So for that we have to take a detailed family history, need a pedigree chart, we have to look for the complete examinations, and if we see the previous child, it is particularly phenotype which suggests the diagnosis of van der Waals syndrome, which is an autosomal dominant condition, and there is 50% recurrence in each pregnancy. So family history can change the diagnosis from multifactorial to genetic. Next case is, all of us might be aware, this is the typical gestalt diagnosis of Down syndrome. So the point I would like to highlight here is, in 95% of the cases there will be a trisomy 21, but in 4% of the cases could be a translocation, and remaining 1% it could be a mosaic. And the thing is, whenever there is a mosaic, the severity of the phenotype would be less. Like this Down syndrome, there are many such single gene disorders where we have some gestalt diagnosis would be there. Let's see how it is. So she is a 2-year-old child who came to us with a short stature. Along with that, if you see, there is particular shortening of the arm, which is basically a rhizomelic shortening, but the head typically is very large. If we see the close facial profile, she had a dolichocephalic head with mid-face hypoplasia and low set anteverted ears. So this is the typical gestalt diagnosis of skeletal dysplasia called achondroplasia. So once we have this phenotype, shall we go for the clinical exome or we go for any other genetic testing? In 98% of the cases of achondroplasia, we have the targeted mutation of the FGFR3 gene. This is in our case also. So in such cases, only the targeted mutation analysis would be sufficient. Next, look at the another case. This case has been sent to us by a cardiologist, where a child had the phenotype along with some pulmonary stenosis. Let's look up the phenotype of this child. Along with the pulmonary stenosis, he had some triangular face with broad forehead, anteverted ears and down slanting palpebral fissure. He is also a short stature. Together with this cardiac anomalies, it defines the phenotype of Noonan syndrome. Now once we had the diagnosis, like previous case, shall we go for the targeted mutation analysis? Which gene we need to test here? In 50% of the cases, PTPN11 is the genetic anomalies, but still there are variations in this. If we look up the previous above row 3 photographs, all are overlapping features of Noonan's phenotype. Almost triangular face with low set anteverted ears, but the mutation gene will be different in all three. While below is the case, there apart from the Noonan's phenotype, there is some overlapping phenotypes. Like here there is a broad forehead, here there is some curly hairs will be there, and this has also a triangular face. These are some minor variations, but they are all the spectrum of the Noonan's. So they are called a Rasopathy spectrum, in which we have different gene mutations with similar phenotypes. So we need to test a common panel of the genes rather than a single gene, so we cannot miss the diagnosis. Now let's look up the next case. She is basically a teenage who has an overweight. Basically she is a 170 kg girl. Previous March 2018 a beauty pageant, she is a winner for disability child. Apart from the overeating, she had some dysmorphism is also there. This is the phenotype of Prader-Willi syndrome. The thing I need to highlight is not the syndrome here, but whenever we had such phenotypes, now next what will be the thing we need to done? We know that there is some abnormality is there. Shall we go for the karyotype in such case? Then it will be normal. Shall we go for the clinical exome? No. Clinical exome will come normal in such cases because this is an imprinting disorder where the sequencing like ATGC will remain normal, but the functional gene silencing will be there. So it might not be picked up in any of the tests. Yeah, if it is a deletion, then might be picked up for the FISH or MLPA. But the best method to diagnose here would be the methylation specific MLPAs. So when we had the phenotype, and then we can decide upon the which genetic test need to be done. Now the next case here would be the one of my patient who is a 11-year-old boy with spasticity and sensory ataxia but absent ankle jerk and bilateral extensor plantar. Basically they came with to us with all the genetic report done. They already did clinical exome and microarray which are normal. They also did mitochondrial sequencing which was normal. Because of the ataxia, spinocerebellar ataxia panel was also done. That also negative. So with all these things they came to us for further diagnosis. So we had to analyze it again the phenotype, and when we look back it fitting into the Friedreich's ataxia phenotype, where it is a triple repeat nucleotide disorders, and the best test to diagnose here will be the specific type of PCR called TP-PCR, and it will not get picked up in any of the routine genetic screening test. So by seeing all that cases, I would like to say that whenever genetic is a very vast spectrum of disorders, presentation could be pediatric or adult, maybe as in some like previous case cardiac or neurology, or it could be a kidney disorder presentation. Child may have a congenital cataract, or presentation could be a sensory neural hearing loss. So we had to keep our eyes open, and then we had to narrow down our diagnosis with careful examination, family history and some of the databases available. We had to note down what is the deviation from the normal pattern. Once we have that phenotype, then we can come to the diagnostic test. For example, if we are suspecting a Down syndrome, we will go for the karyotype. But if we are suspecting a beta thalassemia, we have a common 5 thalassemia mutations which we have to explore. But if we are suspecting a 22q microdeletion syndrome, in that phenomena we have to do microdeletion MLPAs. And if you are suspecting a single gene disorders, then based on the phenotype, either single gene or a panel of gene, or could be a clinical exome. But in case of imprinting disorders, we require a methylation specific MLPAs. And this distinct phenotype will give us the molecular diagnosis, which the most efficient application nowadays, once we have the molecular diagnosis, we can offer a prenatal diagnosis to the parents. It is always a collaboration of the neonatologist, obstetrician and medical genetics, so that parents can have a healthy child in the next pregnancy. And next I would like to focus few points about the genetic counseling. Whenever such patients will come to us, they will have lots of psychological aspects. We have to address that. We have to communicate to the families. We have to explain them the results of the genetic testing and whatever the support groups available, so that they can have a normal quality of life as much as possible. And apart from that, they also wanted to know what is the risk of recurrence in the next pregnancy. So these all points we need to explain them whenever the patient comes to us for the genetic counseling. And last but not the least is the management part. Genetic disorder always needs a multidisciplinary approach, which includes a physiotherapist or occupational therapy, speech therapists may require multivitamins or enrollment in the support groups. But now we had reached to the era where some of the disorders also have some specific therapies are available. For example, for thalassemia or adrenoleukodystrophy, we had a bone marrow transplantation available. In case of lysosomal storage disorders, enzyme replacement therapies are also available. And you will be surprised to know that as of now in Gujarat, there are 5 patients of lysosomal storage disorder who are getting therapies free of cost. Apart from that, spinal muscular atrophy. Recently, all of you must have heard that crowdfunding of the SMA patients for 16 crores. So that gene therapy now we had. So now we had reached to the stages of specific therapies for the patients. So to summarize this talk, I would like to say that medical genetics is always a multidisciplinary approach with clinical diagnosis along with molecular testing and genetic counseling. And we should also not forget 2 other aspects of teaching to the others and make them aware about and educate them, and research, so it will be helpful to all the patients in the long way. And last but not the least, I would like to mention here that under our team of SETgene have now started a new venture called newborn screening, which is already recommended by the WHO and Indian Academy of Pediatrics, under whom there are some disorders where early neonatal screening is definitely helpful to the child, and it should be a part of integral part of the neonatal care. Specifically because if they are not treated in the early phase, for example a congenital hypothyroidism, if we will not treat them in the early phase, it will cause irreversible brain damage. So we should start this cost effective screening as early as possible for all the newborns. With this I am concluding my talk, and I would like to thank Dr. Dilip Gadvi sir, as well as our SETgene director Dr. D.G. Patel sir, and our team of SETgene, as well as my colleagues Dr. Manpreet and Dr. Meeral for their unconditional support for this talk. Now I would like to open a stage for any question and answers. Thank you.
Is there any government help for this kind of poor patients?
Sorry?
Financial help from the government for poor patients?
Basically sir, there are charitable trust access programs are running, few of them by the pharma companies. We can enroll them in that charitable trust access program. And apart from the Gujarat, like Bangalore in South India, because they genetics has established since very long, so their government has already started to provide treatment for such patients. But here now we are collaborating in near future. But as of now, pharma companies are providing free of cost treatment. Under the Department of Biotechnology, basically, sir, they had started this newborn screening program in all over India. So they are the one which are funding this newborn screening in other states. And Gujarat, under the vision of Dr. D.G. Patel, sir, we had now started this venture.
Do we have genetic screening or genetic testing available for pediatric diabetes, particularly when we are evaluating for Modi? So is it available in?
Yes, sir, it is available. If the child, we can test them. Yes, sir. Yeah, for diabetic panels are there for specifically maturity onset diabetes for young. It is there, sir. Yes, sir, it is available.
Thank you, Dr. Payal, for this very informative lecture. I now request Dr. Dilip Gadvi, sir, to felicitate Dr. Payal with a memento.